Good evening, friends, and welcome to another online CME in the series from AMASI, the Association of Minimal Access Surgeons of India. We are pushing the boundaries of minimal access surgery in all fields, and one of the boundaries is in gallbladder cancers. We have a very eminent faculty from Korea joining us today to talk about his experience and the technique of the procedure of minimal access surgery for gallbladder cancer, and a very distinguished panel to really grill the speaker regarding a lot of aspects of this technique. So starting with have Dr. Anil Agarwal as the moderator. He's a director professor and head of GA surgery at GB Pant Hospital in New Delhi. He's among the first to start laparoscopic gallbladder cancer surgery in India. We have Dr. Manas Ranjan Sahu, who is professor and head of surgery at AIIMS Bhubaneswar. He's a keen GI surgeon, extensive experience in HPB surgery. And Dr. Biju Kodakat, professor of GA surgery from JIPMER, Puducherry, a renowned institution for GA surgery in India. He actually organized the ISPB also recently. So before I hand over to Dr. Biju to introduce the speaker, may I request Dr. Verghese for a few words, and then I will ask the first question for the postgraduate residents. Dr. Verghese, please. He's the president of Association of Minimal Access Surgeons of India.
Thank you, Dr. Rajdeep, and welcome all to the AMASI CME program that's happening on every first Thursday of the month at 8 p.m. Indian time. And this time that we have very experienced and well-known speaker from Korea, Professor Wool Kwon, and so much experience in HPV. And as Dr. Rajiv said, we'll be hearing from the professor on carcinoma gallbladder, the minimal invasive surgery applications. And we have a very excellent panel also today, starting with Dr. Anil Agarwal, the HOD and the director from GB Pant Hospital, and Dr. Manas from AIIMS Bhubaneswar, and Dr. Biju Kodakat from the JIPMER Pondicherry. And this program is supported by Merrill Enco Surgery, and it has been going on for the last 1.5 years without any interruption. And it's been actually well attended, but I feel that the attendance should be much more than this. So I request all of you to share the flyer or the information that you are getting on with your friends and colleagues. Apart from this, AMASI also organizes a surgery program then under the banner AMASI Lens every third Thursday. And we have a live demonstration of the surgery during online demonstration of surgery, and it's very popular and well attended. So we have many other academic events that is happening throughout the month, and our main conference, that is AMASICon, is coming up in Hyderabad in the month of August, and starting from August 15 to August 18. So I request all of you to be a member of the AMASI, because once you become a member, you get all the notifications regarding the academic event that is happening. So, and otherwise you'll be missing a lot of the academic the programs that is conducted by the association. With these words, I welcome you all once again and hand over back to Dr. Raj. Thank you very much.
Thank you very much, sir. Prabhu, could I have the first question, please? Here's the first question for the postgraduate residents. There are very good rewards for people who get the answers correct first, but you have to be a member of AMASI. You can become a member later on also. So as per 8th AGCC, the minimum number of lymph nodes harvested in extended cholecystectomy should be, you have these 4 options over here. You have to send the correct answer as question 1 and what is the correct option. You have up to 1 minute. This won't be displayed for beyond 15 seconds, but you have up to 1 minute to send the correct answer in. Thank you, Prabhu. You can close this. Dr. Biju, may I request you to please introduce the speaker? Thank you.
Today we have Dr. Wool Kwon. He is a professor of
Rajdeep,
HPV
Dr. Purnavali sir has joined, so we request Purnavali sir to say a few words.
Good evening, Dr. Pallivellu. He's the founder president of Association of
Sir, you are
Minimal
muted, sir.
Surgeons. So if we could have a
Sir,
introductory words from
muted.
Yes.
Hello. And I'm a little delay for joining it. And today's program is CA Gallbladder. It's very much important. And the speaker is expert in this. I'm very happy to listen. And this is today, present day, when the maximum number of surgeries is going to happen on gallbladder, so that we have to recognize some of the cases pre-operatively also. And then we will not miss. So that way, I think this is a time it is going to be live. And he's going to talk, and I'm going to listen, and you can continue now. Then finally, if anything, I will talk about. Thank you very much for Varghese and Singh. Now, Northern chapter has taken initiative on CA gallbladder, very important. When North India, gallbladder is CA gallbladder is so common, very nice. And we'll look for it. All the best.
Thank you, sir, for your kind words. Dr. Biju, please.
Dr. Kwan is a clinical associate professor at the Seoul National University Hospital, Korea. And he has extensive experience in SPB disease, especially pancreatic malignancy and gallbladder malignancy. He also worked as an associate research scientist at Columbia University earlier. And he is currently the Vice Secretary General of the Korean Association of HPB Surgery, and also he worked as a Secretary General of the Korean Pancreas Cancer Network and the Korean Pancreas Surgery Club also. He has a very extensive publication record, basically in pancreas and HPB areas, both in basic research as well as the surgical aspect.
Social media post
And his recent publications in Annals of Surgery is specifically related to the impact of liver resection in T2 gallbladder cancer. So we are very happy to host you, Dr. Kwan, and I request you to start the presentation.
Thank you very much for a kind introduction. As introduced, I'm Will Kwan. A very, very generous introduction. I'm very thankful for that. I hope you can all see the screen.
Yes, we can see.
Yes, so I'll start. So today my talk is about application of minimal invasive surgery in gallbladder cancer. And with this, I have nothing to disclose about conflict of interest. To begin with, let me start with a little bit of history of minimal invasive surgery in gallbladder. As many of you may know, Dr. Philip Murray here in the picture, he is well known to us for performing the first lap collie in 1985. But what we do not usually know is that there is a surgeon called Dr. Erich Muhe. He's a German surgeon, and he was actually the first surgeon to perform lap collie in 1983, dating 2 years earlier than Dr. Murray. But why do we acknowledge Dr. Murray so much? It is because he was the first one to perform lap collie in the manner that we perform today, using a video visualization. And Dr. Muhe's lap collie that the first one he performed, he used the actual laparoscope and not the video system. So his procedure was not recorded as the first lap collie, but his effort was finally acknowledged in 1985 to be the first laparoscopic cholecystectomy. Since then, so much evolution has taken place. We've been looking for ways to reduce the incision, and nowadays, single incision lap collies are widely performed, and not just laparoscopically, but now we have robotic platforms to do minimal invasive cholecystectomy. And similar to laparoscopic cholecystectomies, robotic cholecystectomies are now being done with single incisions. Since many of you are pretty much of a professional with laparoscopic cholecystectomy and robotic cholecystectomies, this video may not be so interesting, but I'd like to share this video of single incision robotic cholecystectomy done using a Da Vinci SP platform. So this is a case of symptomatic gallbladder stone. The patient had BMI of 23. The duration of the operation was 40 minutes. In this video, I am retracting the gallbladder cranially to have the callous triangle exposed so that I can do safe dissection. And after confirming or assuming where the cystic duct may be around, now I'm starting to dissect around the cystic duct using Maryland bipolar forceps. Now, after cystic duct has been dissected and fully isolated, it is very important to check again and again that what you are doing is around cystic duct and not common bile duct or common hepatic duct, because some patients who has very redundant hepatoduodenal ligament, sometimes common bile duct can be confused for cystic duct, causing a bile duct injury. So after cystic duct has been dissected and fully isolated, I again check the cystic duct to make sure that the common ducts are not involved. And then I clip the cystic duct with Hemlock clips, and then divide the cystic duct using endo scissors. Then I readjust the gallbladder, retract it a little more so that I can get a better exposure on the cystic artery. And here I again dissect and try to isolate the cystic artery, then clip and divide it. Usually the cystic artery that that's gonna go out with the gallbladder, most of the time it's bipolar coagulation is just enough. So after that, with appropriate retraction, the dissection plane between the gallbladder and the liver can be exposed very well. And I usually use a monopolar hook to resect the gallbladder from the liver. At this time, everybody knows that caution should be taken not to perforate the gallbladder, especially in gallbladder cancers. You don't want to encounter that. And after the cholecystectomy's been done, I always make it a rule to check for bleeding or bile leak using a clean gauze. So there's probably nothing very new or nothing very special about that last video, but I just wanted to share a case of simple cholecystectomy. So like I said, laparoscopic or minimal invasive surgery continually evolves, but the evolution seems to go in a way that we are always trying to make things smaller and minimize things, but this is not always true. And what I mean by that is in the past, many surgeons thought that the hepatoduodenal ligaments and many other areas around the liver, bile ducts, and the pancreas to be off limits due to anatomical complexity and high risk of dangerous consequences once things start to go wrong. However, with technical developments and increased surgeons' experience, we now know that there is no such thing as no man's land around this area. Even in radical cholecystectomy, once where we thought it was no man's land, we are now seeing more and more reports of minimal invasive radical cholecystectomy. They can be done with both laparoscopic and robotic platforms, as shown in the pictures, but it should be performed by surgeons with lots of experience and skills in minimal invasive surgery and HBP surgery. And also, of course, those who have been well trained by those experienced surgeons, they can also do these procedures quite well. So at this time, I'd like to now share a video of robotic radical cholecystectomy and gallbladder cancer. And in this video, there's got to be a better voice than mine.
This is a case of 69-year-old female instantly diagnosed with gallbladder cancer in a routine checkup. A CT scan shows the intraluminal mass in the body of the gallbladder with asymmetry enhancing wall thickening, which represents over T2 stage gallbladder cancer. Total 6 ports are placed along the 2 concentric circles centered on the gallbladder, 4 ports for the robotic arms and 2 for the assistant surgeon. First, the 12mm trocar is inserted just inferior to the umbilicus. At the inner circle, R1, R2, R3 ports are placed, and at the outer circle are 4 for the robotic arm and A1 for the assistant, which are 5mm. Note that the trocar position can be changed by the patient's body size. The patient is placed in the reverse Trendelenburg position with legs apart, and the assistant surgeon stands between the patient's legs. We insert the DeBakey forceps into R1, Cardiac forceps into R4, and the curved scissors into R3. Now we begin with the Coker maneuver. Note for the dissection, we usually use the curved scissors, but if there are microvascular structure, we use the energy device through the R3 port. We perform Cokerization until we reach the posterior side of the pancreas head. During that time, the number 13 lymphatic tissues are dissected and put into a small silicone bag. Next, we perform the dissection of the hepatoduodenal ligament. The lymph node 12 in the right of the common bile duct is removed with fine dissection. Further dissection around the hepatoduodenal ligament is achieved to clear out all lymphatic tissues. The right gastric artery is ligated with clips and is resected. The superior border of the pancreas head was dissected, and the number 8 lymph node tissues are collected. The common hepatic artery is slung with a vessel loop and is skeletonized. We continue the dissection of the interior portion of the hepatoduodenal ligament. Then the gastroduodenal artery is identified and again slung with a vessel loop. The lymph node dissection of the anterior portion is now completed. Next, the soft tissue between the bile duct and the hepatic artery is dissected, and the portal vein is visualized. We carry on removing all the soft tissues around the portal vein in order to complete lymphadenectomy. It is important to notice that retraction of the hepatic artery with vessel loop is very useful to clear the posterior part of the portal hepatis. This is the final view of the lymph node dissection around the hepatoduodenal ligament. Now, the cystic artery and the cystic duct are ligated, and the cystic duct stump is sent to the pathology for frozen biopsy. Then, for liver resection, the transection plane was demarcated on the liver 3 centimeters away from the gallbladder. Before transection of the liver, we tacked the round rubber bands on each side of the demarcated line for retraction of the liver parenchyma laterally. Then the assistant inserts the fascial closure at the epigastric area and grabs the rubber band to retract medially. We begin the parenchyma dissection with energy device from the left side. The clip applier and the Maryland bipolar forceps are used for coagulation. After a certain amount of left dissection, we move to the right transection line. here the position of the instruments are changed. The assistant again retracts the rubber band immediately. The liver resection is done in the same manner. Dissection is mainly done by the energy device, and the diffuse bleeding is controlled by the bipolar forceps, and the visualized vessels and bile ducts are ligated with the clip pliers. Then the inferior border is dissected in a cephalad direction to complete the wedge resection of the liver. The specimen is placed in the plastic bag and put aside in the intraperitoneal cavity. It is removed at the end of the surgery. After bleeding control and irrigation, any bile leakage from the liver surface is checked with a clean gauze. A Jackson-Pratt drain is inserted around the resection plane and tagged on the retroperitoneum. This is a gross appearance of the specimen. The operative time was 155 minutes. The intraoperative bleeding was 80 milliliter. The biopsy confirmed that stage T2 gallbladder cancer, and postoperative course was uneventful.
Right, so I hope you enjoyed the video of robotic radical cholecystectomy. So now, as you have seen in the videos, minimal invasive surgery is technically possible in both simple and radical cholecystectomy. And we know that minimal invasive surgery provides many benefits to the patient compared to open surgery, including more cosmesis, less pain, shorter length of stay, less bleeding, and so on. So the question is, why not use minimal invasive surgery for all cases wherever possible? Why we cannot readily apply minimal invasive surgery to the surgical treatment of gallbladder cancer is because the application of minimal invasive surgery in gallbladder cancer is still controversial. The controversy is not whether it is feasible or not technically, but rather the question is it oncologically safe? So is it safe to perform gallbladder cancer operations minimally invasively and gain satisfactory outcomes, survival outcomes? So now I'll talk about that for next 10 or so minutes about the oncological safety of minimal invasive surgery in gallbladder cancer. So let's look at it in two different categories, early and advanced gallbladder cancer, because the recommended treatment differs depending on what stage the gallbladder cancer is in. So early gallbladder cancer, which is T1 gallbladder cancer, are usually recommended for simple cholecystectomy, and advanced, which is T2 and above, radical cholecystectomy is almost uniformly recommended. So first, let's see what evidence we have for applying lap chole or robotic cholecystectomy for early gallbladder cancers. This is an early report by Dr. Yoo-Seok Yoon and Ho-Sung Han at Seoul National University Bundang Hospital. They studied 18 patients with T1A and T1B gallbladder cancer who received laparoscopic cholecystectomy, and all 18 patients survived more than 5 years without recurrence, raising the possibility of oncological safety of minimal invasive surgery in early gallbladder cancer. Also in 2016, a Korean multicenter study that we conducted showed that even after propensity score matching, we found laparoscopic cholecystectomy to have comparable result to open cholecystectomy in terms of oncological outcome. There were no recurrence among 94 patients, and the 5-year survival rate of these patients were 94.9%. But why is minimal invasive surgery in early gallbladder cancer still so controversial? This is the Japanese clinical practice guidelines revised in 2019, and it still opposes laparoscopic cholecystectomy and recommends open cholecystectomy as a rule. But the grade for the statement is 2, and the evidence level is C. But let's take a look at what reason they have for opposing minimal invasive surgery even in early gallbladder cancer. One of the main reasons is the risk of peritoneal dissemination. The guidelines state that there is about 10% risk of gallbladder perforation in general during laparoscopic cholecystectomy, and the prognosis becomes significantly poor once the gallbladder is perforated in patients with gallbladder cancer. But the reference that they use for these statements were papers that were published in 1999 and early 2000s. So now about 30 years have passed since popularization of laparoscopic cholecystectomy, and I feel that the perforation rate in non-inflamed gallbladder is much lower than what was reported in the past. While I do agree that biospillage in gallbladder cancer patient is associated with poor outcome, let's take a look at this paper from Germany. They analyzed 837 incidental gallbladder cancer patients in the German registry and found that 23% of the lab colleagues had macroscopic gallbladder perforation, which I think is a little too high, but nevertheless, even in open cholecystectomies in their series, they experienced 21% of them experienced gallbladder perforation. So the gallbladder perforation rate between minimal invasive and open surgery is not very different. So this raises the question whether open cholecystectomy ensures safe operation and minimal invasive cholecystectomy has higher risk of perforation. And based on my personal experience and most of your experience would point to the same direction, that open is not always safe and laparoscopic is always dangerous. I do not believe in that. So it is not whether it is open or minimal invasive access that matters, but actually what matters is the effort, what effort you're putting in to avoid perforation. And I think that is very important in gallbladder cancer operation, whether open or minimal invasive. So I would recommend adhering to the liver bed when removing the gallbladder. This would not only prevent you from making perforation, but also theoretically, it will allow you more safety margin circumferentially. And another reason for opposing minimal invasive surgery in the Japanese guidelines is the risk of port site recurrence. And according to their literature review, the risk of port site recurrence was around 50%. But again, most of the literature they cited were from late 1990s and early 2000s. When I do operations, whether cancer or benign, I usually use laparoscopic specimen bags, which will reduce the risk of spillage substantially. So, and I have not experienced any port site recurrence in my 15 years of experience. And the report of port site recurrence is very rare, even in other cancers, not just gallbladder, but gastric cancers and colon cancers and whichever cancer that utilizes minimal invasive surgery. So I don't think it is fair to prohibit the use of minimal invasive surgery in early or incidental gallbladder cancer. Next, I'd like to talk a little about T1B gallbladder cancer. As you can see, the recommended surgical extent of T1B gallbladder cancer differs from country to country. So radical cholecystectomies are recommended by the NCCN guideline and many of Western countries. For Japanese, they recommend just simple cholecystectomy. In Korea, we leave it to a surgeon's preference, whether you want to do simple or radical cholecystectomy. So this, we still do not know what exactly to do. So in a meta-analysis that we conducted, we found that the long-term survival was not different whether the patient received simple cholecystectomy or radical cholecystectomy. And also our multinational, multi-institutional retrospective study also showed that there was no difference in 5-year survival rates between radical and simple cholecystectomy. And among these 116 patients who have received simple cholecystectomy, the 5-year disease-free survival rates were comparable between those that underwent laparoscopic and those that underwent open cholecystectomy. Therefore, I think that laparoscopic cholecystectomy or robotic cholecystectomy is safe not only in T1A gallbladder cancer, but even in T1B gallbladder cancer. And this meta-analysis is a nice summary of oncologic safety of laparoscopic cholecystectomy in T1 gallbladder cancer. There was no difference in survival rate at 1, 2, 3, and 5 years between minimal invasive surgery and open surgery in T1 gallbladder cancer as a whole. So in summary, for early or incidental gallbladder cancer, I think minimal invasive surgery is both feasible and oncologically safe as long as you pay attention, pay caution to prevent gallbladder perforation, pay attention to minimize tissue manipulations, and to use plastic bags when retrieving the specimen. And now I'd like to move on to a minimal invasive radical cholecystectomy. Now I'm back to the old paper of Dr. Yoon and Dr. Han. In this study, they also looked at the result of resected T2 gallbladder cancers, and he demonstrated with 25 patients the possibility of minimal invasive surgery even in radical cholecystectomy with 5-year survival rate of almost 90%. Their later study also showed that laparoscopic radical cholecystectomy had comparable outcome to open radical cholecystectomy in T2 gallbladder cancers. And in node-negative subgroups, the outcome was even marginally superior. P-value was not 0.05, but a little less than 0.1. So they showed marginal superiority of laparoscopic radical cholecystectomy in selected node-negative patients. Another study from Korea also demonstrated a comparable 5-year disease-free survival and 5-year overall survival between laparoscopic and open radical cholecystectomy. And this meta-analysis again also demonstrated a comparable 3 and 5-year survival rate in T2 gallbladder cancer. And in this meta-analysis, when we look at just 1 and 2-year survival rate, laparoscopic radical cholecystectomy was more superior than open. Going further, laparoscopic distal radical cholecystectomy yielded comparable or better survival rate in T3 gallbladder cancer. And it is not only laparoscopic radical cholecystectomy that you can achieve satisfactory oncologic outcome. This is our early study looking at early outcomes of robotic radical cholecystectomy. When comparing 16 robotic radical cholecystectomies to 34 open radical cholecystectomies, all the perioperative short-term outcomes were similar between the two operations, and robotic cholecystectomy significantly reduced the length of stay for the patient. We built on this previous study and published a comparison of 41 robotic radical cholecystectomy with propensity score matched open radical cholecystectomies. And again, here we found no difference in short-term outcome, and the only differences that we found were less blood loss and reduced hospital stay for the robotic radical cholecystectomy. But more importantly, the 5-year overall survival rate and the 5-year disease-free survival rates were both similar to open radical cholecystectomy with 92.3% of overall survival and 72.5% of disease-free survival. Thus, the oncological safety of robotic radical cholecystectomy. So going back to the question of can minimal invasive surgery be applied to gallbladder cancer? Technical feasibility we already saw in the videos. And oncological safety, I've introduced some evidence that points to oncological safety of minimal invasive surgery in gallbladder cancer. However, I must acknowledge that these evidence may be affected heavily by selection bias. But let me put it another way. I'd like to use the word, instead of selection bias, I'd like to use the word careful selection of patient instead. So I'd like to answer this question with, yes, minimal invasive surgery is applicable to gallbladder cancer, but in well-selected patients. So these are my take-home message, my last page. So minimal invasive surgery is beneficial in terms of cosmesis, hospital stay, post-operative pain, intraoperative blood loss, and more. But both simple and radical cholecystectomies are all technically feasible, but oncological safety is the key issue that we should continue to think about. Recent studies demonstrated similar oncologic outcome between minimal invasive surgery and open surgery in both early and advanced gallbladder cancer, but there is definitely some selection bias. So larger scale studies and well-designed prospective studies are needed to strengthen the role of minimal invasive surgery in treating gallbladder cancer. And with that, I'd like to thank you for all your kind attention. Thank you very much.
Thank you very much, Dr. Kwon. And before I open it for discussion among the moderators, Prabhu, could I have the second question, please? So in a patient of gallbladder cancer, in which of these following conditions is bile duct resection not indicated? And these are the 4 options. So leave it on for about 20 seconds more, and you can send in your answers as question 2 and whatever is the correct option. Right. Thank you, Mr. Prabhu. Thank you very much. As I hand over to the moderators for the questions, please. Dr. Anil Agarwal, Dr. Manas Ranjan Sahu, and Dr. Vijay.
Thank you very much, Kun. Really enjoyed your talk and your videos of excellent display of the robotic radical cholecystectomy and the literature supporting. And I was very happy to see your paper in which I think your numbers have really swelled up for the robotic radical cholecystectomy. And the question, I think in the robotic radical, you showed that interaortocaval lymph node sampling also you are doing. So is that a routine that you do and you would abandon, or in selected cases, you would still go ahead for resection?
You mean for early gallbladder cancer?
I mean, any stage gallbladder cancer in which interaortocaval lymph node is positive.
Mm-hmm. For advanced, so T2 or over, we make it a rule to do appropriate lymph node dissection, the extent of which we think is number 13, one behind pancreas, number 8 around common hepatic artery, and number 12 around hepatoduodenal ligament. That is always a rule, even if there's no suspicion of lymph node metastasis for T2 and or above. We always do lymph node dissection. For T1, that's very tricky situation because T1A and T1B have different lymph node metastasis rate. For example, T1A, we would expect about 5% or less to have lymph node metastasis. For T1B, goes up a little to 10 to 15%. So for T1B, we would not feel so safe leaving lymph nodes untouched, but the problem is we won't know whether it's T1A or T1B until the final pathology comes out. So sometimes when I think it's really early or maybe incidental gallbladder cancer, I would maybe just pick some lymph node around cystic duct or a little bit around common bile duct that's very near to cystic duct, kind of a little bit like sentinel lymph node concept. So if I'm worried about lymph node, I would do just a little for T1 gallbladder cancers, but if I decide to do extended a radical cholecystectomy, I'd always do proper lymph node dissections.
So probably the lymph node dissection that you're talking about for T1B, you are referring more to the incidental gallbladder cancer, right?
Yes.
Because I think, as you said, that in a previously diagnosed gallbladder cancer, you couldn't be sure that you are dealing with T1B.
Mm-hmm.
And you showed about the controversy because the Japanese literature talks about simple cholecystectomy in incident, and you talked about in Korea it is controversial. But I think one of the issues is that because we know that T1B, the lymph node positivity is there.
Mm-hmm.
So whether you are able to, do a R0 resection, so to say,
yes,
because I think the literature that you showed, I think it's more a statistical that you shared 95% versus 93 or 92%. But whether when it goes to beyond maybe 10 years or even beyond, so any comments on that?
Well, let me first continue on the lymph node dissection according to the T stage. So always, if there's a little suspicion of gallbladder cancer at our center, we always use high resolution ultrasonography or MRI because they can give you more better idea on the depth of invasion. They can even sometimes correctly decide whether it's T1A or T1B, not just T1 and T2. So most of the time I would do extra workup using high resolution ultrasonography or even endoscopic ultrasonography if available. And if most of the studies point to T1A, then I would just leave the lymph nodes alone. If there's some discrepancy between the studies, then I would go with the more harsh result.
Or on the side of removing more lymph nodes rather than leaving it like that. Right?
Yes.
Yeah.
And
Dudu and Manas.
Yeah.
Dr. Manas, please. Yeah.
Dr. Kwan, that was a wonderful lecture. In fact, you clarified many things about gallbladder cancer. I truly appreciate, but I just wanted to know, you told that most of the lab colis in your institution are done robotic, is it? Or all of them are done robotic?
At our center, no, we at the moment, about 20% are done with robots and 80% are done laparoscopically. The main reason is there's limited resource of robotic equipment. And also there's currently the Korean government do not cover the insurance of robotic surgery. So patient has to pay like 4 or 5 times more than what you would have to pay when you get laparoscopic cholecystectomy. So we are doing both, sometimes on our preference, sometimes we go with the patient's preference. So we are now doing both laparoscopic and robotic.
So if it's your preference, how do you choose that whether I should go for lab or robotic, leaving aside the financial part of it?
Okay, so this is my very personal opinion. I do not represent other Korean surgeons or other all biliary pancreas surgeons. I personally think that robotic cholecystectomy and laparoscopic cholecystectomy, between them, I don't think there's extra benefit of using robot. And like I said, because Korean government does not cover the insurance, it's way expensive than robots, way expensive than laparoscopic. So although, yeah, with robots, sometimes the patient feels better, maybe a little bit of quicker recovery, but I don't think that price difference is compensated by that little benefit. So for me, I limit robotic cholecystectomy to patients who request to have their cholecystectomy done with robotic platform. But for some surgeries, I think robots have definitely much more benefit than laparoscopic. But for simple cholecystectomy, not that much. But that's my real personal opinion.
Okay. Okay. How often you encounter the middle hepatic vein while dissecting the liver?
In our hospital, we just stick to wedge resection, meaning about 2 or 3 centimeter of a wide margin. We do not do anatomical so-called bisectionectomy.
Okay.
So we do not try to go very deep, especially if it's not if it's in fundus, you don't have to go very deep on the towards the hilum. So for us, we do not meet middle hepatic vein that much. Maybe we might meet a tributary of middle hepatic vein. But for those, you can easily clip and coagulate those vessels. So we don't see much difficulty with middle hepatic vein.
And it was not very clear that with Dr. Anil's question that when the intra-aortocaval node is positive, do we still proceed or you just retreat back?
Aortocaval, it's also my personal strategy. If it's aortocaval, if it's just right behind hepatoduodenal ligament around there, then I might just continue with the operation. But if it's much lower aortocaval, I would think it's more of a systemic problem. So, but I don't know, aortocaval, it's very difficult to define. You can kind of stick it to the hepatoduodenal ligament. Sometimes you can just call it a systemic. But if I would decide to go on with the surgery anyway, I think I would convert to open surgery and try to do more dissection and get more samples of distant lymph nodes. So yeah, I think that would be my strategy for that.
If I may, specify that further, I think you are talking about the posterior superior retropancreatic lymph node, which is the one, like as you said, that which is embedded almost in the pancreas there, and just behind I think at the junction between where the the bile duct and the pancreas is there, and behind that. So, but that lymph node, like we know that the Japanese and Korean consider it as a loco-regional, and we also consider it like that. But the other is specifically, which is the 16B1 lymph node, which is in the groove or in the pre-cable region, that is the intra-aortic cable. So I think, as you said, that if it is deeper down there, which we would call it as 16B, as the literature suggests, so those are the ones which we would also very selective. Like at the moment, as per the current literature, those are considered metastatic, and probably you may not justify a resection. However, in selected centers, in selected cases, with advancement in the chemotherapy and other adjuvant therapy, you may choose, right? Yeah.
Yes, I would agree. But the thing is, unless you suspect number 16 lymph node metastasis, you wouldn't usually go that far or that deep to collect number 16 lymph nodes. So usually it wouldn't be part of my operation plan, but sometimes we would see enlarged lymph nodes on the more posterior side of pancreas. In those cases, we might do maybe biopsy of number 16, but usually we would try to exclude those patients preoperatively by looking at CTs and PET if necessary. And it is suspected, then we would not planned operation at all. But yeah, sometimes, instantly we find these big lymph nodes in retroperitoneal area, and we might go for a biopsy in those cases and decide whether to go on with the operation or not.
When do you contemplate any neoadjuvant therapy?
Sorry, I didn't catch you.
Any neoadjuvant protocol ever you follow in carcinoma gallbladder?
Neoadjuvant, it's more for us, it's more of conversion or palliative chemotherapy rather than neoadjuvant, because definition-wise, neoadjuvant means, although it's resectable, you do chemotherapy beforehand. For gallbladder cancer, since chemotherapy, there's no established chemotherapy regimen or exact indication for chemotherapy, I think the role of chemotherapy is very limited. So we have some cases where we did preoperative chemotherapy, but those were advanced patients that we thought the common hepatic artery or lymph nodes around hepatic arteries were so aggressive that we deemed it unresectable. Sometimes we would do chemotherapy, and very little portion of those patients come back for possibly resectable cases. So for us, we do not apply neoadjuvant chemotherapy for gallbladder cancer, but there are some fortunate patients who successfully endure their chemotherapy and they have good response and come back for a conversion operation. Yes, sometimes we encounter those patients.
So you very categorically told that in your 15 years experience, you have never had any port site metastasis. Am I right?
Yes.
Okay. So do you ever contemplate port excision in any incidentally found gallbladder cancer planned for a radical cholecystectomy?
Not now, but if I experience one or two cases of those situations, then I might have to consider. But so far, no, I haven't had it, and I haven't heard my colleagues, Professor Zhang and my other colleagues we work together, we haven't encountered any of port site metastasis. So at the moment, no, we do not consider doing a port site excision. But I heard that some surgeons do a little bit of excision around port sites. But for me, no, I do not see a benefit of that at the moment.
Can I put a supplementary question on that?
Yeah.
Yeah, because I think when you are talking about port site metastasis, meaning that incidentally detected gallbladder cancer, and as you have not seen in your experience when the cholecystectomy has been done at your center, but however, these may be coming from several places. And as you said in the literature that you quoted about 20%, you said that there may be bile spillage into the peritoneum. Right. So, I mean, would that put at a little higher risk of their developing a port site metastasis? So, would that alter your management whether the incidental gallbladder cancer is following a cholecystectomy done at your center or any other center that you know of, versus it is coming from, let's say, an unknown center?
Well, I am not sure, but well, I'd have to look at their a person has received a laparoscopic cholecystectomy and the final pathology turns out to be more advanced than initially thought, and they would come back for additional operation on lymph node dissection and liver. In those cases, I don't know, maybe I'd have to look at the operation record that they bring from their original hospital. If it was really uneventful operation, no spillage or any other problem, then I would not consider doing anything extra on that, but just do more lymph node dissection and the liver wedge resection. Other than that, no, I wouldn't.
I mean, it's interesting that you're talking about the discharge slip. I think, at least in our country, in our center, we haven't seen many discharges mentioning that there was bile spillage. I think a lot of time, because maybe it is not, because you're not suspecting gallbladder cancer, so not so much significance is attached to a little bit of bile spillage while you are doing a cholecystectomy. And so I think it may not always be, the discharge slip may not always be reflective of that there
Yes.
was bile spillage. And in fact, in some of them in which the discharge slip is pretty clean, you find that there are spilled stones when you go in back for a completion radical cholecystectomy, which obviously means that there was bile spillage. So you have indirect evidence. So I'm just saying that we have been arguing, and we're in the process of writing paper because we have seen quite a few outside metastasis, and because in our country it is not a practice in all the centers to bring out the removed gallbladder in a bag.
The plastic bag, yeah.
So that is another thing. So I was talking to Jarnagin on the sidelines of one of the IHPB conference in India, and I realized that we were talking about two different groups, because there the practice is to bring out the gallbladder in a bag, whereas for us that's not always so common.
All right. Okay.
I think this is a very clear message we can give to our colleagues, I mean junior colleagues, that all lab colleagues, they should try to remove in an endo bag. That in fact obviates many a problem. You agree with me, Dr. Anil and Dr. Kwan?
Yes, I do.
Absolutely.
Yeah.
And I also agree with Dr. Agarwal that even if there was perforation, some people might not like to write a note about that because they don't want to look bad or anything. So yes, I think there are possibilities that notes may not always tell you the truth.
Yeah, true.
Okay,
Okay,
just you shifted to MRI in a significant way to assess the T stage. That's what I understood. And how often you use intra lab ultrasound probe to assess the T stage? Do you use it?
I have high confidence in our radiology colleagues, so I trust pretty much what they tell me, and I do not trust my my ability of interpreting ultrasonography. So I go with the our radiologist friends. If they tell me it looks like T1A, then I decide to trust, and I don't use ultrasonography that much intraoperatively because, for one thing, it takes time. It adds cost to the patient, and it's a limited resource. So I just go with whatever our radiologists tell me. So I do not use intraoperative ultrasonography that often, or almost never. Yeah.
Dr. Rajdeep, yeah. Do you have any other questions from
So one aspect from the general surgeon is that they have gone in, they put in a scope in, and they find that the gallbladder is not looking good. Maybe it's thickened. So the fear is always there. It may be malignancy, it may be xanth. So whatever the reason may be, maybe they didn't get a recent ultrasound. In fact, this happened today itself to one of my colleagues. So what do you advise them to do? Should they abandon simple cholecystectomy, take simply a wedge of the liver and leave it? What should be done? This open to the entire panel.
Oh, that's a very difficult question. So in your question, the patient is in the OR to get a cholecystectomy, but doesn't look as simple as it is expected.
Yeah,
in
exactly.
that case. That's actually very difficult, and I think there are many things to think about. Like what is the incidence of gallbladder in the area you're working in, or where the patient came from? Wow, I think that's like almost like flipping a coin. See what to do.
Take it for granted that the person operating is not an HPB surgeon. And we have a
Oh,
very high incidence of gallbladder cancer here.
okay, then I would definitely recommend to just leave it there and send it to a specialist, because like we said in the presentation, once things start to go bad, then it's going to be catastrophe. And sometimes this was a experience of also my young colleague. The patient, after laparoscopic cholecystectomy, was found to have high-grade dysplasia adenoma, but there was spillage while doing cholecystectomy, and the patient had a peritoneal carcinomatosis in like 3 months' time. So I think it's really just like one mistake that you make that puts the patient in a very harmful place. So if you are not certain, if you don't feel confident about giving proper treatment, then I would rather have the patient sent to a specialist. I think that's more beneficial to patient than going and trying to solve all the problem by yourself.
What's the opinion of Dr. Anil Agarwal, Dr. Manas?
Yeah, I think I can tell you from the last week experience that we had. It so happened that we had 3 cases in the last week. In one case, we did what Professor Hahn had advocated in his first paper in 2010, in which the index of suspicion was there. So what we did was we took out with a wedge of liver. And I think that is what is advocated, because rather than breaching the plane of the gallbladder and the liver, and that turned out to be chronic cholecystitis. And this was a patient, so that was it. So we could, manage just with that, and we didn't go ahead for lymphadenectomy. The second patient we had, which was yesterday, the day before, in which it was that it appeared the index of suspicion appeared to be low, even though it was thick-walled on the pre-op imaging. So we did only a cholecystectomy and sent that for histopathology. That also turned out to be benign. But surprisingly, the patient that we operated today, again, we were thinking that's thick-walled, but maybe, chronic cholecystitis xantho. There was a nodule which was found separate in the peritoneum, in the ligament there, and which, when we took out, was reported as metastatic adenocarcinoma. So, it can be variable, but the message which would be is, which Professor Kuhn very rightly said, that if you thought that the index of suspicion was high and you were not in a position to do a radical cholecystectomy, and radical cholecystectomy means not only the liver and the gallbladder, but also the lymphadenectomy, then it is preferable to refer it to, as he said, that just bring out the scope and just send it, refer it. But otherwise, if you think that you can do a wedge resection, then as in Professor Hahn's series, 50% of the patient turned out to be benign. So you could just do with that. And then depending on whether you are routinely doing a laparoscopic lymphadenectomy or not, you can decide to do an open lymphadenectomy or a laparoscopic lymphadenectomy. So that is what I would, based on our experience, I would like to see.
I think, Dr. Rajdeep, I agree to both Dr. Kohn and Dr. Anil that if the surgeon is not experienced and he finds a case where the index of suspicion is quite high, he should just retreat back. There is no point in making the things messy. But if otherwise somebody is experienced, then he has a choice. If the index of suspicion is low, yes, go ahead with the cholecystectomy and wait for the biopsy and then go for a completion. That's also another option. But otherwise, if you are experienced, I think you should go ahead with a radical cholecystectomy for the benefit of doubt. If it turns out most of the time a xantho, it doesn't make situation worse. Because around most of the time, many a time that comes as xantho than a carcinoma gallbladder.
Yeah, I think I'll just re-emphasize the point that if you do not have the facility of frozen, and you are going
true.
ahead,
Absolutely,
then you can do a radical cholecystectomy, and it's not heaven's lost if it turns out to be benign, because the first may be more, consequential. And Professor Kuhn, can I ask you 2 quick questions?
Yes,
One
please.
is that in your talk, you talked about the robotic. I mean, is that your preferred approach in minimal access, or also you do laparoscopic? And if you do laparoscopic and robotic both, do you have a preference, or is it logistical reasons depending on, as you said, the cost factor and whether the instrument is available or not?
For radical
Yes,
cholecystectomy,
yes, for radical.
I started my minimal invasive robotic cholecystectomy with robot in the first place. So my preference is definitely robot because I'm so used to doing it with robot. I am not very familiar with using the stiff laparoscopic instrument for liver resection. The reason more that I think is even if I am familiar with laparoscopic, I think I would still stick with robotic because as you've seen in the video, the left side is pretty easy because you get a nice view. But when you want to do the left side, you really don't get a nice view. You are kind of looking from the side and the instruments are going this way. So having the wrist movement of robots, I think it has definitely advantage going into places where you cannot get direct access and visual access as well. So robots has very good advantage over laparoscopic when doing liver resection. Before a lymph node dissection, no, I don't feel that laparoscopic is inferior to robot. So it actually depends on where you want to go, what you want to do. And I don't know, maybe I'd have to learn a lot from more laparoscopic master of laparoscopic radical cholecystectomy. Maybe that I might feel safe. But since I started my minimal invasive with robot, I stick with that.
Right. And the next thing was that do you take some cases which needs, let's say, a bile duct resection or with some adjacent viscera resection in terms of part of the stomach and duodenum or colonic resection, or what's your approach in those cases?
Well, theoretically, I think you can do everything minimal invasive for resecting bile duct. I mean, what's the difference with doing bile duct resection in pancreatidodenectomy or doing bile duct resection in colorectal cyst? But I think it's a matter of the extent of disease that is actually the problem. So is it the right patient? Have we selected the right patient to do minimal invasive surgery, or do we just need to do more? Do we have to think of more radical and more extensive operation? So technically, yes, I think we can do additional organ resection, such as bile duct or nearby colon or a little bit of duodenum, but I don't know. For that, we'd have to think about the oncologic safety, whether it is correct to do it or not. But I think there is very limited data on that. So I think that's something we'd also have to think about in the future as well.
So I think you about PET scan, you mentioned CT, you mentioned MRI. So does PET scan form a standard part of your investigative protocol?
No, it is not, because also we're very much controlled by the government and the insurance system. PET scans are not covered by the insurance, and we can't use it routinely. So we only use PET when there is some findings on CTs that you can suspect some things that you did not expect. Then you can use PET, but otherwise you cannot. So no, it's not a routine workup we do. But if we saw para-aortic lymph node enlargement on CTs, then we can perform PET scans. So very selectively we use PET scans.
And in the video, you showed the dissection of the hepatic artery. So does the dissection extend right up to the celiac axis, or it's only the hepatic artery proper?
we do not expose the whole celiac axis, and we usually do not see the bifurcation of common hepatic and splenic artery. So we start a little bit near to gastroduodenal artery, and I think if we look at the length of common hepatic artery, I think we do about 2/3 of the length, 2/3 to 3/4. We don't go all the way to the celiac axis.
Right. Any other questions or comments, Dr. Anil, Dr. Manas, Dr. Biju?
Dr. Kwan, if a surgeon wants to upgrade himself to a minimal invasive radical cholecystectomy, which case he should be choosing first, in your opinion?
Which what?
Which case he should start off?
Easy ones.
So how you consider those easy ones?
Maybe just suspected T2 gallbladder cancer, and you don't see much lymph node enlargements around hepatoduodenal ligament. Possibly tumor is located more on the fundus side instead of infundibulum or the body, because there you have much more safety margin, even if you don't go very deep into the hilum when you're resecting the liver. So yeah, maybe fundal T2 gallbladder cancer with no suspicion of lymph node dissection might be a good case to start with. And always lean patients are nice.
Yeah, okay. Thank you.
Do you always go for wedge resection, or sometimes you go for bisegmentectomy?
Wedge resection, unless there's extensive invasion into the liver, because our policy of our team, the policy of our team is that the aim of doing liver resection is to acquire safety margin rather than to block anatomical drainage of lymphatics and things like that. So we just think about 2 or 3 centimeters of extra margin is enough. And there was actually a paper that our group wrote about T2 gallbladder cancer, and we were able to compare some hepatic wedge resection and S4B and S5 segmentectomy, and we found no difference in the outcome. So we decided to stick with just doing wedge resection until otherwise other evidence comes out.
So you are happy in robotic using the harmonic and the the bipolar for transaction, liver transaction, or you at times feel the need for a QSA?
I think for wedge resection, we don't encounter that much of large vessels to
bisegmentectomy.
Well, in those cases, we might have to use a CUSA, but for wedge resection, I think this energy device and bipolar is adequate enough to stop the bleeding from minor vessels.
Right. Thank you, Dr. Kwan. It was a fantastic discussion. Dr. Biju, any concluding remarks before we close up?
No, that's fine. Please go ahead. Yeah.
So before we close, I would like to invite Dr. Debarshi, and I'll invite the concluding remarks again from the moderators. Dr. Debarshi is the Secretary of the Association of Minimal Access Surgeons, is the National Secretary. Dr. Debarshi, please.
Thank you, Rajdeep. I had some family issues, so I had to be away a little bit. Rajdeep, I think you can do the honors. You can give the Thanksgiving and can do that, I think.
Thank you very much, Dr. Debarshi. So any concluding remarks, Dr. Anil?
No, it's fine. And Professor Kuhn, really enjoyed your talk. And I think just a word about, because, as you said that because you started your minimal access using robot, but in terms of all the people who are doing, and because a lot of, in India, I think more of people are doing the laparoscopic and some robotic as well. Like we in our experience, our robotic is limited. We have only done about 5 robotic, and rest of the ones are laparoscopic. So I think, but what we say is that actually speaking, the outcome for the patient is the same. In the sense, it's comparable in terms of what you are doing for the patient, in terms of the adequacy of resection, oncological, and also the lymph node yield, etc. So, but the only thing is that, so whatever you are comfortable with, and especially that if you are not used to doing advanced laparoscopic procedure, probably graduating from open to robotic may be easier than going from open to laparoscopic. So that might be a thing, but otherwise I think it is comparable for both. Yeah. And thank you very much, and thank you for the invitation, Amasi, for this moderating this.
Thank you, sir. Dr. Sahu?
Thank you, Dr. Kwan, for a wonderful discussion, and I think you make this gallbladder cancer management very simple and very logistically approachable. You made things very clear. I think most of the things that we discussed must have benefited the surgical audience across. Thank you very much.
Thank
And
you.
thanks, Razib, for the opportunity.
Thank you. Thank you very much, sir. Dr. Varghese is here for the closing remarks. Yes, sir.
Yeah, Rajdeep. Yeah, I think that I also agree that it was a very wonderful session on carcinoma gallbladder. In South India, we don't see much of carcinoma gallbladder, but compared to the North, I think the incidence is very high. So I think that this discussion would definitely benefit a lot of our surgeons, and that they can update on this topic. And thank you very much, Dr. Knon, for your acceptance to be here today for this CM. Thank you very much. And thanks all the moderators for your valuable time. Thank you.
Thank you, sir. Thank you very much. Dr. Kwan, Dr. Anil Agarwal, Dr. Biju, Dr. Manas. Thank you very much.
Thank you.
This is one of the upcoming programs. We have a live demonstration of radical cholecystectomy with lymphadenectomy, which is coming up on 23rd of May at 3 p.m. It's also Thursday. So I request everybody who's interested to please join. Thank you very much.
Thank you.